spinal cord, and it's going to go to the ganglia, that cell body on the outside. It's small in diameter, but it is myelinated. So these are those type B fibers, those guys that can do about 40 miles an hour. So sometimes we'll see these referred to as preganglionic fibers, which again is just short for saying the axons of the preganglionic neurons. So instead of that big sentence, we just whittle it down to preganglionic fibers. So that's who's going to be the first guy in the series. The second guy in the series is the ganglionic neuron or postganglionic neuron. So some books use ganglionic because it's cell bodies in the ganglion. Other books will say postganglionic to keep with the pre and the post kind of name setup. So this guy is completely in the peripheral nervous system, cells, bodies in the ganglia. The axons are going to extend to the effector organ, so the smooth muscle, cardiac muscle, the glands. It is small and unmyelinated, which means it's a type C fiber. It's got to go 2 miles an hour. So again, when we look at the control of our skeletal muscles, the somatic motor neurons are usually type A neurons. So they're going 300 miles an hour straight to the skeletal muscle from the central nervous system. When we look at the autonomic nervous system, the first guy's going 40 miles an hour. The second guy is going 2 miles an hour. So again, you're going to have that delay. When we exercise, our skeletal muscles instantly start working harder, but it takes a while for us to start sweating. It takes a while for our blood pressure to go up. It takes a while for our heart rate to go up. Because again, these guys have 2 communicators. One's slow and one's slowest compared to this skeletal muscle. And again, sometimes we'll refer to these as the postganglionic fibers, which is just short for the axons of the postganglionic neurons. So there's our series. So our pre-guy, cell body in the lateral gray horns in the spinal cord or in the brainstem. They're going to leave as a part of the ventral root, and they are myelinated. So they're going about 40 miles an hour, and they will synapse onto the postganglionic cell. And that postganglionic cell completely in the periphery. Nobody touches the brain or spinal cord. And it's going to be a little bitty skinny guy, unmyelinated, so 2 miles an hour going to the effector organs. This illustration just shows you it doesn't matter where, which one you are. Sometimes you're long, sometimes you're short. So sometimes the first guy is long, sometimes the first guy is short, sometimes the second guy is long, sometimes the second guy is short. It just depends on where we're going from, where we're going to. Now, autonomic responses, again, we've got that handout online for what's going on in the parasympathetic division, what's going on in the sympathetic division. So examples of what we would expect to find with autonomic responses, changes in the dilation of the pupil. So whenever you are in the sympathetic division, you're stressed, you're lying, your pupil is going to dilate. Whenever you're relaxed or you're telling the truth, you're going to be in the parasympathetic division. It's going to stay the same or constrict. Dilation, constriction of the blood vessels. So dilation, usually parasympathetic. Constriction is usually sympathetic to raise blood pressure. Adjusting the rate and force of heartbeat. So increase heart rate with sympathetic, decrease heart rate with parasympathetic. Increase or decrease in the gland activities. And it depends on the gland. So obviously, when we're stressed, our sweat glands are going to produce more, but our spit glands will produce less. So you'll have a variety of responses. Now, we can't control these consciously, right? You can't stop your armpits from sweating. If you could, we wouldn't need deodorant because you just, give it a look and it'd stop sweating for you. We can't control our heart rate. We can't control the dilation of our pupil, stuff like that. Since we cannot voluntarily control these guys, they make good indicators of if the body is stressed or if the body is relaxed. It's one of the reasons why we check those things when someone's in the hospital or someone is, hooked up to a lie detector or something. Now, even though we cannot voluntarily control them, we can affect them because, again, the autonomic nervous system is influenced by the limbic system, our emotional system. So if we relax and our emotions go down, that can lower our heart rate. And of course, breathing is tied into that, and you can consciously control breathing. So by relaxing, deep breaths, meditative activities, yoga, that slows down your heart rate over time so it can lower your blood pressure, lower your heart rate. So you can't make it do it automatically, but you can influence these. Now, since some of them can't be swayed greatly, again, they're often used for polygraph tests because polygraph tests pick up if you're lying. And unless you're a sociopath, when you lie, you stress a little because you're not supposed to be lying. This is one of the reasons why they're not admissible in court, because they just pick up stress responses. So if you have a lie detector, they're going to hook you up to a heart rate monitor. The fancy ones will have breathing monitors that wrap around your chest. Some of them will have little pads that they put in your armpits to pick up if you start sweating. Some of them will have computers with video cameras to watch your eyes. So again, if you're lying, your pupil will dilate. If you're telling the truth, your pupil will constrict, or your heart rate's going to go up if you're lying, or go down or stay the same if you're not lying. So they're just looking at those patterns of responses. Now, they're not always going to be 100% accurate because they're just picking up stress responses. So if you're nervous about the lie detector test, even though you're telling the truth, it can come off as a lie because you're nervous about the whole effect. If you cough a whole lot, that raises your heart rate, that raises your blood pressure, that's going to throw off your responses. If you have a pain sensation, so one of the ways some people used to beat polygraph tests was to put a tack in their shoe, and anytime, or just randomly, they'd step on that tack, and that response would show up as a stressor because of the pain of that tack, and it would throw off the results. And of course, if you're a psychopath and you have no feelings, nothing stresses you out. So nothing's going to be perceived as a lie. So again, they're just a way to try to lead investigators, but they're never going to be the end-all be-all because they are fallible. You can mess them up on purpose or not on purpose, depending on how you feel about your lie detector test. So our divisions of the autonomic nervous system, we have the sympathetic and the parasympathetic, the stressed and the non-stressed. Now, most of your organs are going to have dual innervation. You'll have impulses from the stress state, the sympathetic. You'll have impulses from the parasympathetic. And usually they're going to be the opposite. If when stressed, your heart rate might go up. When you're relaxed, your heart rate might go down. So again, when you have that handout online, that's how it's set up. It has two columns with the sympathetic and the parasympathetic, and you can go through it. It says this increases heart rate, this decreases heart rate, this increases sugar production, this increases sugar storage. So typically they have the direct opposite effects of each other. So the nice thing is if you know what one does, you know what the other one does because it's going to be the opposite. And of course, the sympathetic, again, is our stress state. Think of anything that happens when you're stressed, anything that happens when you have that adrenaline rush, right? Your heart rate goes up, your sweating goes up, your breathing goes up, all those kind of things. So that's what's going to happen with the sympathetic. So typically one will increase the activity, one will decrease the activity. So there's our activity. So again, our sympathetic, the stress state is going to cause vasoconstriction. This is going to raise blood pressure, which is why people who have very stressful jobs tend to have high blood pressure because they're always stressed out. If you are in the parasympathetic, you're relaxed at home eating Cheetos, next week you'll have vasodilation. That's going to cause your blood pressure to go down. And here again is those people. So we get stressed out, we get nervous, our pupil is going to dilate. That in theory is because back in the day, the thing that would stress you would be predators trying to eat you. So a bigger dilated pupil can let more light in so you can see the predators lurking to get you. So they would dilate. If you're in the parasympathetic, you're relaxed at home eating Cheetos, it's either going to stay the same or constrict. And this leads to several different things that we see in our culture. One is the myth you can't look somebody in the eye and lie. You totally can. Good liars actually make eye contact more than bad liars do. But if you're skilled, and that person is talking to you and your pupil dilates, it could indicate that they're lying. But on the flip side, whenever you're attracted to somebody, that actually kicks you in the stress state. So they may be lying to you, or they may be attracted to you, or they may be lying about being attracted to you, or they're looking at somebody far away in the corner. Okay, so that's why it's not 100% unless you know that person's feelings, because it could be a lot of issues. This is also why anime characters have huge eyeballs, in case you've ever wondered why anime eyes are so huge, or 90s, early 2000s Disney characters have huge eyes. It's psychological. When we see huge dilated pupils, we pick up at that as somebody is interested in you. It actually causes your body to release oxytocin, which is a bonding hormone, so you can be just as attracted to them as they are to you. So this is why anime characters have really big eyes. It helps to engage the audience and helps to sell their products. Same thing with the Disney characters and those big googly eyeball stuffed animals that they always have at craft stores, checkout stands. Y'all know what I'm saying. Those really freaking cute dragons with giant eyeballs. You just can't help it. They're so adorable. Why? Because when you look at them, you're like, look at those big old eyes. I'm releasing oxytocin. I like it. It makes me happy. Okay? High amounts of oxytocin is your orgasm hormone. So this one just says, I like you. And sometimes you like somebody way a lot.
So seeing that through a dilated pupil through a screen could release oxytocin?
Yeah.
So it's kind of like they're getting you addicted to whatever content they're serving you.
Mm-hmm. And
my
you
God.
feel bonded to that character. Why do you
What?
think so many people like Tweety? That is one freaking annoying bird. He has really big eyeballs, and people really like that. Or the Little Mermaid. She's still, kicking it after decades. Why?
Wow.
First one with big old eyeballs. Bonded with that thing.
Wow.
Yeah, it's all psychological. When you see those big eye things, it's the same reason why women wear smoky eye or dark eyeliner. It helps
Big
to
eye.
darken the eye, even though your pupils aren't dilating from a distance, you appear darker, so you're more attractive. So they've been doing that for centuries. The ancient Egyptians used to do stuff like that. Well, yeah, it's all about manipulation.
Oh my God.
Get what you can.
Brujeria.
People be tricky. You gotta watch out, especially them big old eye people. It's also why kids have big eyes. Well, that and your eyeballs don't grow, so they're the same size as they are in adults. You grow into your eyes. Isn't that weird? They come out the same size. But it's one of the reasons why babies have big eyes. It's so you like them, because if something wakes you up at 2 o'clock in the morning, you're probably not going to want to love on it. But babies have big old eyes and they just stare at you. You're like, okay, you're kind of cute. Helps us to bond to our kids, because our kids are very painful when they first come out. And then, of course, they're annoying as hell because you have to feed them all the time. But they have big eyes, so they're adorable, so we like them. Ooh. Yeah, so there's reasons why babies have big eyes. Always think of Puss in Boots, right? You need a big eye thing to get people's attention. It works. Very psychological. So the sympathetic division, also known as the thoracolumbar division, because the paracarons of those preganglionic neurons are going to be found in the 12 thoracic segments of the spinal cord and the first 2 lumbar segments, so in the lateral gray horns. And they, of course, lead as a part of the ventral root. It's also on the street known as your fight or flight responses. So everything going on when you're fight or flighting, that's going to be the sympathetic division. Again, most organs are going to have input from both divisions. So our sympathetic, we have increased heart rate, increased blood pressure, increased breathing, increased sweating, decreased digestive urinary activities. That's why a lot of times if you have to give a speech, you may get cotton mouth or dry mouth, because when you're stressed, your spit is going to be produced less, and it's going to be more mucousy, less watery. So it becomes a sticky kind of spit that's not very thirst quenching. So our mouth gets really dry when you get nervous because of the sympathetic division. We're also going to decrease digestive activities, because if you're running for your life and you stop to go to the bathroom, that's when they're going to get you. Okay, same thing with the urinary thing. You stop to go to the bathroom, they're going to get you. Increased energy demand. So you're going to see mobilization of sugar. So we can get the sugar to the muscles so they can run away. That scenario.
What is release of urination while you're in sympathetic mode? What is that called? Is that some sort of defect?
No. Some people get scared and wet their pants, and that's just because you lose the voluntary control of the external sphincter. It's not the autonomic system. It's you're so scared you forget to control your exit ports. Because we're consciously having to clench all the time so we don't pee. And we get scared and we forget to clench.
You do the same thing whenever you're laughing.
Yeah, you get distracted. You forget to clench. And depending on how well your sphincters are, laughing changes your abdominal pelvic pressures. And if it puts pressure on the bladder will go, and if you don't have good sphincters, it'll just squirt past. Kind of like if you pee when you sneeze or cough and stuff like that. That's pressure changes. Because your sphincter is only as strong as your voluntary control over it, just like any other skeletal muscle. So if you lose control of it, it loses functionality. So that's why you do all those Kegel exercises, to strengthen your exit ports, so you don't accidentally wet yourself. Guys can do Kegels too. Girls are just known to have to do them more because of birthing, ruining all of your exit ports down there. Don't have children. It messes up your exit ports. Okay. Then you got to gain control of that sphincter again. So here showing you again the preganglionic guys, T1 through L2. Axons are going to leave and go to the ganglia. We're going to have our sympathetic chain ganglia. They're found in little clusters that look like chains going down. We have the collateral ganglia, which means to the side. And then we've got our adrenal medullae. And then they're going to go to the target organs. Same thing, just with pictures in their organs. So one of the ironic things is, again, when we're on sympathetic division, it causes our pupils to dilate. That actually kind of is a backtrack from the spinal cord activity. It's not actually from the cranial nerve. So it's a little weird how that one kind of goes up, kind of against the stream, so to speak, by controlling all those organs. So our different pathways are different ganglia locations. We've got the sympathetic chain ganglia, and they're called that because they just look like little chains of bubbles going down the thoracic cavity. So they appear to be like, chains. So preganglionic fibers will synapse onto one or more of the sympathetic chain ganglia. They're going to control everything above the diaphragm. So the head stuffs, the dilation of the pupil, the thoracic cavity, the body wall, so increasing heart rate or breathing rates, not enough saliva, sweaty armpits, all that's going to come from the sympathetic chain ganglia. The collateral ganglia, again, to the side, that's because they're not in the chain, they're to the side of the chain. They're going to go to the abdominal pelvic viscera, so below the diaphragm. So those preganglionic fibers are going to pass through the chain ganglion, kind of like, driving through Tucumcari on your way to San Antonio, that'd be a long trip, on the way to Santa Fe or Albuquerque. So we bypass those chain ganglia and then synapse onto the collateral ganglia. Now these axons are really long, and instead of saying the preganglionic fibers that are heading to the collateral ganglia, sometimes we'll just call them splenic nerves, which sounds really funny. It sounds like something Adam Sandler would randomly say in a movie. But that's just a splenic nerve is just short for the preganglionic fibers heading off to the collateral ganglia. We have 3 different collateral ganglia. They're each going to control different regions of the abdominal pelvic viscera. So the celiac ganglia, the term celiac means stomach. So it's going to go to the stomach and say, stop digesting. It's going to go to the liver and say, release sugar so we can run away. It's going to go to the gallbladder and say, hold the bile. It's going to go to the pancreas and say, you need to release glucagon instead of insulin so we can mobilize stuff. It's going to go to the spleen and say, prepare in case we're bleeding. We might need some extra blood. It's going to go to our second collateral ganglia. We have the superior mesenteric. That's going to be most of the small intestine. That's going to say stop absorbing and digesting. It's going to go to some of the large intestine and say stop absorbing and digesting. The inferior mesenteric ganglia is our last guy. It's a little bit lower down. It's going to go to the large intestine and say don't go to the bathroom. That's why sometimes when you get stressed out, you get constipated. You'll have some people who have constipation linked to travel. It's like, oh, I'm going on vacation. I'm not going to poop for a week. Well, some people get stressed out when they travel, and that causes you not to go to the bathroom as frequently. It's going to go to the kidneys and say, pull that fluid out of what would be urine so we can utilize it so you produce less urine, which leads you to urinating less. It also goes to the bladder and says, hold it so you don't urinate as frequently. It goes to the sex organs and say, have an orgasm, because sex organs are weird. The rest of the body's going, we're all going to die. And the ovaries are like, yeah, we are. So sex organs are just weird. Okay, so they're a little odd that way. Then we have the adrenal medulla. So again, the adrenal glands are little glands that sit on top of the kidneys, and the medulla is their center, kind of like the peanut of a peanut M&M. Now, the adrenal medulla releases hormones, epinephrine and norepinephrine, or on the street, adrenaline and noradrenaline. So what happens, those preganglionic fibers are going to synapse on neuroendocrine cells. This is a neuroglandular junction. So instead of having a postganglionic neuron, they're going to have a hormone-releasing cell, and they're going to release epinephrine and norepinephrine to kick up that big adrenaline rush to help get you through the moments that you need to be able to run for your life or fight for your life in that kind of scenario. So here's showing you the guys, again, going to the chain ganglion. So from the lateral bighorns out through the ventral root to the chain ganglion. This was showing the ones going to the adrenal medulla. So very long preganglionic fibers synapsing onto those neuroendocrine cells. So instead of a postganglionic neuron, it has a hormone-releasing cell, so we can release adrenaline to run for our lives. Okay. This is showing everybody. So cell bodies in the lateral great horns, leaving as a part of the ventral root. Again, some are synapsing onto the chain ganglion. They're just in a little chain. Some continue past that point to the collateral ganglion. So that's that splenic nerve. So we can tell the digestive system and urinary system, reproductive system, what to do with their life. Okay. Here's our celiac ganglion. So they're controlling this region. Our superior mesenteric ganglion controlling this region. And our inferior mesenteric ganglion that's going to control this region. And you can actually see the chain ganglion in the background, okay, that they're bypassing. Okay, so here's our pre-guys bypassing. So the splenic nerves synapsing onto the collateral ganglion. And then we have the postganglionic fibers going to the organs. Okay. Big Bad, any questions? Seems plausible. I didn't make up anything. I know splenic was kind of sketchy, but I didn't make up that word.
Mhm.
Our parasympathetic division, I'm at home relaxed eating Cheetos division, so next week. Also called the cranial sacral division because it's going to come from cranial nerves. So ocular motor 3, facial 7, glossopharyngeal 9, vagus baby, vagus 10, and of course the sacral region. So when we look at a division, you've got the parasympathetic, sympathetic, sympathetic, parasympathetic. It's almost like a sandwich going through. So the top and the bottoms are going to control your parasympathetic division. Now, the vast majority is controlled by the vagus nerve, 75%, because it's the vagus nerve that's going to affect your heart rate, your breathing, your digestive activities, all those guys. Again, as we learned, vagus nerve is the only cranial nerve that will be fatal if you sever it, because you won't be able to control your heart rate, you won't be able to control your blood pressure, digestive activities, all that kind of stuff. So your parasympathetic division would be out the window. It would almost drive your body towards the sympathetic division in its activities, which would just wear out the heart from over contracting. So patterns of responses, what we would expect when we're resting, when we're digesting. So increased saliva activity, increased digestive activity, lower heart rate, lower blood pressure, lower breathing, increased digestive functions, urinary functions. Now the effects are very localized. Okay, so if you can kind of think of it, when you're stressed out, everybody's instantly stressed out. But when it comes time to relaxing after being stressed, it takes a little while to bring everything back down. And that's because we have to go to every single organ system and release those neurotransmitters to calm them back down. We don't have a big hormone rush to help dictate everything. Okay? It's just like Friday nights, in the evening, sometimes it takes a little bit to wind down before the weekend can get going because life sucks. Okay? You got to tear down. And it may take you longer to fall asleep if you have a stressful day because it takes a little bit longer to get into this division because everybody has to be told directly instead of having a big body hormonal response. So here's showing you the guys coming from the cranial, and there's vagus going to all the bits and pieces, and then the sacral, which is just going to your bladder and your sex organs. So not really covering a whole lot of ground with the sacral part. Now, there's lots of ganglion for these. We're not going to cover all the ganglion because I don't want to. It's a good reason. And there's a lot of them. And some of them have the same name, like intramural ganglion, like they're playing sports with each other or something. So we're not going to go into the different ganglia for the parasympathetic division like we did with the sympathetic. Visceral reflexes. So this is where your heart increases its contraction force if we need more oxygen, that kind of stuff. Your stomach digests if you put food into it. Now, visceral reflexes, unlike somatic, are always going to have two motor neurons. There's always a preganglionic and a postganglionic cell. So they have to be polysynaptic, right? When we did our stretch reflexes on test 4, they were monosynaptic, sensory on the motor, very straightforward. This one, sensory motor, or sensory interneuron motor. So we always have more neurons. We can't have a monosynaptic reflex. Now, the autonomic nervous system, again, the sensory component coming in, are mostly visceral pain fibers. So we're having something so much that it hurts, and that's how we're going to respond to those internal pain receptors. Now, they travel along the exact same sensory pathways as some of our somatic pain receptors. It's kind of like we talked about before. If you were to look at I-40, it's hard to tell people from Oklahoma versus people from DFW because they're both on I-40 and they both drive horribly. So it's kind of hard to tell them apart. Same thing here. This also explains why we have that referred pain, and we talked about that before, which is why sometimes when people have heart attacks, they feel like their left arm is hurting. The brain is used to the left arm complaining about life, so it's just going to interpret it as a left arm problem, not the heart, because it's not used to the heart complaining to the point that it's noticeable. So our referred pain are because of the way those visceral reflexes are coming in. Now, if it takes a long time to respond to a visceral reflex, that means the central nervous system is involved, right? If you involve your boss, it's always going to take longer for a decision to be made. Okay, so things like going to the bathroom. Since we can control urination voluntarily, we have that stretch of the bladder as it gets full. That sends a signal to the spinal cord. Now, if we didn't have the brain to do input, you'd pee instantly. But it's not polite to pee instantly every time you got to go potty, right? Yeah, it'd be such a messy place. Okay, so we got to hold it sometimes. So we're involving the central nervous system so we can delay that urination reflex. until it's appropriate to get rid of that urine. If it takes a short time to respond, that means we're not including the brain. Okay, we're not including the central nervous system, so it can respond very quickly. All right, switching gears a little bit, revisiting our neurotransmitters. We've already hinted at these, and we're just going to keep beating the dead horse. So when we look at neurotransmitters, the synapses can be based on or named based on the neurotransmitter that we release. So we have chlorogenic synapses and anergenic synapses, those two types of synapses within the autonomic nervous system. So chlorogenic synapses release and respond to acetylcholine. Okay, so this is going to be our main guide. The synaptic terminals are going to have branching neurons, and they're going to have those varicosities. And we learned that back when we did the muscle chapter, and when we were talking about the neuromuscular junction, we talked about how smooth muscle has varicosities into this very wide diffuse junction, so the neurotransmitter acetylcholine would eventually drift down to the stomach to tell it to empty or something. Now, the effect tends to be short-lived because, as we learned with our bonus work, as soon as acetylcholine is released, it's almost immediately broken down by acetylcholinesterase. So we're going to clear out the command to contract or what have you fairly quickly. Now, chlorogenic receptors are the receptors on the postsynaptic cell, so the doorways into the receiving cell that we are going to have that response. Now, neurons that are a part of our chlorogenic synapses, all of your sympathetic and parasympathetic preganglionic neurons. So all the pre guys, the first guy in the series, are always going to release acetylcholine. The parasympathetic ganglionic neurons, so the postganglionic guys that are parasympathetic, are all going to release acetylcholine. The only sympathetic ganglionic neuron that releases acetylcholine are sweat glands, which is why you can use Botox to treat sweaty armpits, right? So that's one of those things that's popular nowadays. You can use Botox to get rid of your wrinkles. You can get Botox to stop your armpits from sweating too much if deodorant and stuff like that isn't working for you. And that's how Botox can work on your sweaty armpits, because those sweat glands are going to release sweat when they bind to acetylcholine, and Botox prevents acetylcholine binding and release. So it's going to stop your sweating armpit. So all of your pre guys are going to be chlorogenic synapses. All of your para are going to be chlorogenic synapses. Only the sympathetic sweat glands are going to be the postganglionic guys that pick up acetylcholine. So our two types of receptors, the two different doorways acetylcholine can come into the cells. Our first ones are nicotinic receptors. So both of these are named after a drug that mimics acetylcholine. So it's close enough molecularly to trip that receptor. So nicotinic receptors are always stimulatory. They're always going to cause either a contraction, or they're always going to cause the release of more neurotransmitters. So they're going to be present on the cell membranes of the dendrites, the cell bodies of the sympathetic and parasympathetic ganglionic neurons. I know, big sentence. But the second guy always gets stimulated by the first guy. It's like a relay race, right? Remember relay races back in like elementary school? The first person handed the baton to the second person. What does the second person always do when they get the baton?
Run.
For a moment there, it's like, y'all aren't going to be on my relay team. Okay? The second guy always runs in response to the baton. The second guy, the postganglionic cell, always gets stimulated by the pre guy. Okay? He's going to run with it. Also, our neuromuscular junction. So our skeletal muscles always contract in response to acetylcholine. They're called nicotinic receptors because, again, nicotine is close enough chemically to acetylcholine to trigger these guys to respond. So if you look at certain pesticides, most of your pesticides you can purchase at like Walmart, the active ingredient is actually nicotine. So what happens is it gives an OD, an overdose of nicotine to the bugs, and if you watch them, they twitch before they die. It's because they're having lots of nerve firing, and of course they have a lot of muscle contraction as they're twitching because they are overstimulating those muscle cells. If you were to be exposed to too much nicotine, so if you chain smoked like 5 packs in one day, wow, you must be rich because they're expensive. Or if you were to expose yourself to nicotine-based pesticides, you'd start twitching as a side response because of those stimulation of those cells. Muscarinic receptors. Now, these guys can be inhibitory or excitatory. Just depends on where that door is located. So they're going to be present in the membrane of smooth muscles, of cardiac muscles, and glands innervated by the parasympathetic postganglionic neurons. So again, they're named for the mushroom poison muscarine, which will stimulate these little guys. So depending on who goes, which one we're looking at, we're going to have different results. In cardiac muscle, that muscarinic receptor causes the heart to slow down. So this is how mushrooms kill you, okay? And it's that joke that all mushrooms are edible, sometimes only once, okay? So those ones that kill you fairly instantly stop your heart from functioning, okay? Anytime you have a drug, whether you're doing shrooms or a synthetic drug, if you have to give them an EpiPen to the heart to counter it, that meant that drug is going to mimic a muscarinic receptor. It's going to stimulate that muscarinic receptor. Smooth muscle, usually with the smooth muscle of the blood vessels, it causes relaxation of the smooth muscle, drops your blood pressure. But in the digestive system, the stomach, the intestines, small and large, it actually speeds up their activity. So if you do shrooms and you survive the trip, you'll end up vomiting a whole lot or diarrhea a whole lot. So I hope the trip was worth it because you're going to be a mess for a few days. And some of it, you projectile vomit fairly quickly after consuming. So don't do drugs, kids, especially these because, messes. Yes.
Do those cause any changes in the brain, throughout the brain?
Oh, yeah, that's why people take them. Nobody takes shrooms for the diarrhea.
I mean, like death to any brain cells or anything?
If they overstimulate the brain cells, it can kill them. But if you get just enough, it'll cause the ones in the auditory area to fire and the visual areas to fire. So you see pretty color hallucinations and auditory hallucinations. So if you watch the movie Young Guns, they all take peyote to talk about the spirit road and where they're going to go. They do the different scenes that's supposed to mimic or show you what they're experiencing because of the drugs they're taking. One guy just starts vomiting real fast because too much peyote for him. The other one starts talking really slow and calls his horse a dog, and he's shooting at imaginary chickens. It's really working with his brain at that moment. And it shows, if you notice when you watch the show, all their voices are very low. All of their speech is very slurred and slow. That's to indicate their heart rates are slowing down, the blood pressure is slowing down. So the way they filmed those scenes indicates a slowing reaction time with those parts of the body. And again, if you take too much, your heart's just going to stop. So don't do shrooms. It's awkward. Nicotine does not activate muscarinic receptors, so you can't smoke a cigarette and cause your heart to slow down. You can't smoke a cigarette to lower your blood pressure. You can't smoke a cigarette to make yourself vomit. I don't know if anybody would want to do that. Muscarine does not stimulate nicotinic receptors. So if you do shrooms, you don't twitch before you die. You just go to sleep or vomit a whole lot and go to sleep and die. So you don't have any muscle contractions in response to muscarine because muscarine cannot stimulate nicotinic receptors. Now, obviously, both of them are stimulated by acetylcholine because that's what they're made to do. So it's very similar to when you have keys that are close enough they can open locks they're not supposed to. So back in like the 90s, you could use a Mitsubishi truck key to open up the toilet paper roll keys at McDonald's and then run off with the toilet paper rolls. Yeah, then you use those to toilet paper people's houses because then it's no money on you, right? I remember back then people used to toilet paper your houses. Oh, memories. You got to be evil about it. You got to get plastic forks to break it off into the ground so they can't just pull it off the ground. You got to have a squirt bottle to slightly moisten it so it sticks to the foliage. Apparently nowadays there's like cameras on everybody's house so you can't toilet paper properly anymore. Ruining all teenage fun. Now we have to go do hardcore crimes. But anywho, those toilet paper holders at McDonald's were not made to be opened by Mitsubishi keys, but Mitsubishi keys were just close enough, the right shape, you could jimmy them open. I don't know about today. I haven't tried to steal toilet paper from McDonald's this century, but back in the day it used to work. Okay. So this is showing you those, again, the sympathetic guys and the parasympathetic. So the first guy always releases acetylcholine. The second guy has nicotinic receptors, so he always gets stimulated by that release. So he's going to run with that message. The parasympathetic division, everybody releases acetylcholine. And the receptors on the cells are musocrinic. So some cells are going to excite, some cells are going to depress. In the case of the sympathetic, the fight or flight responses, a few of them going to the sweat glands release acetylcholine, everybody else releases norepinephrine. And of course, when we have the receptors on your sweat glands, they are musocrinic receptors. And in this case, when they get stimulated with acetylcholine, they're going to cause you to sweat. So the musocrinic receptors would be stimulatory on your sweat glands. So opposite of your heart, that kind of scenario. That's why sometimes you also get very sweaty when you do shrooms. They're all getting stimulated and causing those reactions. Don't do drugs. Anergenic synapses, everybody that doesn't pick up acetylcholine. So those are most of the sympathetic ganglionic neurons except for your sweat glands. They're going to release and respond to the neurotransmitter norepinephrine. Now, the enzyme for norepinephrine is monoamine oxidase, MAO. And you may have heard this one if you listen to enough drug commercials, because they'll say things like, if you're on this depression medication, do not take if you've been taking an MAO inhibitor. So the early school for depression medication was an MAO inhibitor because that allowed norepinephrine to linger longer, stimulate those happy areas of the brain longer, allowing you to be happier. Okay. Now we know that some people, they need more neurotransmitters versus the MAO control. So some of the newer ones give you norepinephrine, but if I'm giving you norepinephrine, you've got to come off of the MAO inhibitor because that can double dose your norepinephrine, which would cause a heart attack. Nobody wants that. So that's why you can't take those two types at the same time. It's one of the many reasons why depression can be so tricky. If it's norepinephrine related, if you have heart issues, epinephrine, norepinephrine speeds up your heart rate. If you have depression, one of the ways to help them, again, is to give them more norepinephrine. That makes their cells happier. But if you give them just more norepinephrine and they already have heart problems, that speeds up heart rate even more. That can cause a heart attack and cause high blood pressure problems. So you can't take that route. When you have heart problems, arrhythmias, they sometimes give you beta blockers so your heart can slow down, your blood pressure can go down. But they don't want to give you beta blockers if you're suffering from depression because that can make you even more depressed. So this is one of the many reasons why there's so many different types of heart medications and so many different types of depression medications, because depression and heart problems can be very closely linked. And you don't want to slow your heart rate down so you don't have a heart attack, but cause such bad depression that you're suicidal. Kind of, defeats the purpose. You're going to end yourself. So they do have to be careful. So people who have depression and heart problems, they have to go through different drug combination trials to see what works best for the heart controlling as well as the emotional side of things as well. That's why you have those issues when you have heart problems and depression problems, because fixing one can cause more issues with the other. Now, norepinephrine is going to bind to those anergenic receptors on the postsynaptic membrane, either causing excitation or inhibiting depending on the receiving cell. Now, anergenic receptors bind to both norepinephrine and epinephrine. Epinephrine is strictly a hormone, okay? Adrenaline is strictly a hormone. Now, norepinephrine was discovered first as a hormone being released by the adrenal medulla, but later, once we got better tools, we also noticed that it was a neurotransmitter. So norepinephrine can be strictly a neurotransmitter released by the brain, or it can be a hormone released by the adrenal medulla. So you have options with norepinephrine, or epinephrine is always just a hormone. Yes?
So when people take like sugars or drugs, what indicates like if they have a good trip or a bad trip? Is it like how much they take or?
In part, it's the amount, because that's going to trigger ever-increasing number of cells. And sometimes it's their mindset. If you were already thinking negative thoughts, you're probably going to have a bad trip. If you were already thinking positive thoughts, then there's a better chance that you're going to have a good trip. It depends a lot on the person's point of view. It's kind of like some dogs bite you when they get scared. Other dogs run and pee on themselves when they get scared. It's just a behavioral conditioning they have. So with your shrooms, you'll get the same scenario. And in some cases, if you just have a few cells triggered in one area, it can make you feel good. But if you have too many cells triggered, it can cause different issues.
Because I've heard some people say, like some people can take certain drugs and they're fine, and some can say it was like the worst thing they've ever taken, but they can handle it each time. Is it just their body, everyone's body's different? Mm-hmm.
Yeah. What doors in your brain are we opening today? Kind of thing. And you can have two people side by side, I guess licking on the same mushroom and have very different effects of their body. Don't look too much, heart will stop. That'll kind of ruin your trip. Now, the receptors that pick up the norepinephrine, epinephrine, we have alpha receptors and beta receptors. And then we're going to have subtypes. We have alpha 1 and beta and alpha 2s, and we have beta 1, beta 2s, and beta 3s. Typically, your number ones are excitatory because think about it. When you're number one, you're excited that you're number one. Now, alpha receptors are super excited. So they're like those people that body paint themselves team colors and start a riot when their team wins the Super Bowl or something. Beta ones are happy their team won, but they're not going to go crazy or streak or anything like that. The twos are typically depressive because when you're number two, you're the first loser. Okay, so no one's going, yay, we're number two. You suck still. Okay, so you still suck. So alpha twos would be like those fans that cry because their team lost the Super Bowl. Beta twos would be like, yep, we lost, move on. Okay, so super duper responsive when we get to the alphas, mildly responsive when we get to the betas. Now, beta 3 receptors are only found on the cells of brown adipose. So we learned way back in histology. Remember histology? If not, you've got until Thursday. I know, the F word's coming. All right, so again, our brown adipose is only found in fetuses and infants, and it's used for thermogenesis because babies can't shiver. It's just too complicated of a body reaction. Heck, they barely realize they have feet, let alone how to control their body enough to shiver. So whenever a baby releases epinephrine or norepinephrine, the beta 3s are going to burn the brown adipose to cause body heat, help them to stay warm. And then once they burn through all their stores, that's when they lose their baby weight. They look normal. So you can remember that the beta 3s help with body heat because baby, beta, brown. So the beta receptors are on the brown adipose that's only found in babies. So the 3Bs for beta 3s. Now, most of the cells either have alpha receptors or beta receptors. Typically, they're not going to have both for most of our body cells. A few might, but most of them are going to have one or the other. So as mentioned, the alpha and the betas were named based on norepinephrine responses. Norepinephrine stimulates alphas more strongly than the betas. So super excited or super depressed when we look at the alpha guys. Now, our activity of norepinephrine will be terminated at the synapse. Either one, the norepinephrine is taken up by the cell that released it. So if you are the the post guy releasing to the effector organ, if you release 20 norepinephrines and you decided that was too much and you bring back 10, that's going to stop the reaction. So you can reabsorb those neurotransmitters to stop the activity. Or we can break it down by the enzyme. So again, we have monoamine oxidase, MAO. We also have kethyl methyltransferase, chemistry. So CMOT. So those are the two enzymes that break down norepinephrine. Now, compared to acetylcholine, the effects of norepinephrine last much longer, right? You can get a good scare and still feel the adrenaline rush, still have your heart racing, 30 minutes to an hour after the jump, right? Because sometimes the scare lingers. Pretend something was actually scary. There's a final this Thursday. Oh, that'll linger for a while. Okay, so the reason why it lingers more than acetylcholine, because acetylcholine is only released as a neurotransmitter. So it's immediately going to be broken down by acetylcholinesterase. With norepinephrine and epinephrine, they can be released as a hormone, and that hormone circulates in the body. The blood does not have a MAO. The blood does not have any enzyme to break down epinephrine or norepinephrine. So it's going to circulate until the neurons use it. So if you release a ton of adrenaline because you just jumped out of an airplane, that adrenaline is going to be circulating in your bloodstream until every cell that can absorbs it. So you'll have that high heart rate for minutes, sometimes hours after the effects, or you'll have sweaty, not sweaty. For some reason, I'm very excited about sweaty today. It's awkward. It's like I should be on an Old Spice commercial, right? Hi, sweaty. I'm sweetie. Hey, those people need counseling, or more so. But it's one of those things that this is going to linger. We're going to have the effects. Your heart's going to race. Your breathing's going to increase. You're going to have all those issues with epinephrine for longer periods than you would with acetylcholine. So it's going to take longer to calm down after those events because you have to use it all up instead of having it break down. As long as it's lingering and flowing in your bloodstream, you're still going to have responses to it. Bless you. Okay. Now, epinephrine stimulates both alphas and betas equally. Okay, so the alpha and beta designation was based on neurotransmitters on norepinephrine. Epinephrine can walk into an alpha and stimulate it as much as it does a beta, or vice versa. So drugs, don't do drugs. All right, so beta blockers, as the name suggests, they block beta receptors. Life was this easy, we'd all pass pharmacology. Okay, so beta blockers, sometimes you'll see them called anergenic blockers because that's what they're doing, is they're blocking those anergenic type of receptors. They are going to target beta-1 receptors. So beta-1 is going to cause the heart rate to go up. Beta-1s are going to cause blood pressure to go up. So if we block them, this can help reduce blood pressure. If we block them, this can help slow down heart rate. So oftentimes it's used to treat high blood pressure. It's used to treat arrhythmias, those kind of issues by preventing the heart or the smooth muscles from being stimulated by epinephrine or norepinephrine. Anticholinergics are going to target your cholinergic synapses. The classic one we have is atropine, and you've probably heard about atropine. It's one of those drugs that you see on almost every medical show as they're rushing somebody into surgery. They need so many cc's of atropine stat. So this is a drug they give you right before surgery, and it blocks the parasympathetic division. It causes you to have a stress response. Now, at first, it sounds like, well, stress response, you don't want that. You want to be relaxed going into surgery. The stress responses are for the digestive system and the urinary system and respiratory system. So that way you don't make a lot of mucus, because when we're relaxed, we tend to make a lot of mucus. And if you make too much mucus when you're lying on your back in surgery, you could choke on that kind of stuff, right? It could clog up the mechanical respirator, that kind of scenario. It also prevents you from making so much urine. If it's a long surgery, they'll always cath you so that it automatically drains, but they won't have to empty the bag as frequently when you're on atropine. And it stops your bowel movement so you don't have an accident while you're in surgery. This is why when you come out of surgery, a lot of patients, one, complain of dry mouth. Like, I'm so thirsty. Why is my mouth so dry? Well, you probably haven't made spit for like an hour or so. Got a little toasty in there because of that atropine. And the doctors always monitor and ask. So after you come out of surgery for the first 24 hours, you have to pee in the special compartment of the hospital toilet that measures your urine, right? Because they have the measuring component and not component, and make sure the measuring's down. And they're like, oh man, do you know how much you peed on? Pick you out. So they're going to measure your urine so they can know what comes in based on your IV and what you've been drinking, what's coming out. So we know the urinary system's working properly. And they're going to ask you, have you pooped? Even if you have or haven't, they'll give you a nice little stool softener to help ease your exit, okay? They want to make sure you're working. That's one of the things they have to check before they release you. If you don't get atropine cleared from your system, you won't urinate and you won't poop. So not urinating, that's going to cause a major backup in the system. So that can cause a lot of health concerns. And of course, constipation can be fatal. It takes a little bit longer than not urinating. But they want to make sure all the ducts and all the exit ports are doing their thing before they release you. So, one of the joys of being nurses, measuring pee outputs. Tricyclic antidepressants, one of the classic ones is Elavil. They're going to relieve depression by prolonging the activity of norepinephrine at the postsynaptic membrane. These are those MAO inhibitors. So if we don't break down norepinephrine, it lingers longer. We can stimulate the cells more. They can be happier. So for some people, that works. Other people, it doesn't work so well because they don't release enough norepinephrine to begin with. So that's when they would have to switch depression medications to try to address that issue. Hypertension, anything that overstimulates the sympathetic division, whether it's stress because you have Testapalooza this week, or stress because your boss sucks, or stress because a lion is trying to eat you. If you get stressed for too long, it can cause high blood pressure, health problems that way. So hypertension, again, is closely linked to all the issues that might happen when you're in the sympathetic division. And aging. Well, as we've learned so far in life, as you get older, it gets worse. So what happens? We have structural changes of those preganglionic neurons. They become congested with those neurofilaments. So we pointed to, well, we didn't actually point to them, but those little black lines on the model, the neurofilaments that give support and stability like a cytoskeleton to the axons. As you get older, things sag. So your neurons, to prevent sagging, make more neurofibrils to give them more support. And unfortunately, if you have too many neurofibrils, it interferes with the release of neurotransmitters. So it can slow down the activity of the autonomic nervous system by clogging things. Okay. Questions about the autonomic nervous system? All right, switching to memories. It's like, oh, where was this when we've been studying all semester? All right, so when we look at memories, we have two basic types. We have fact memories. It's like, that's the color blue, fact, right? There's no debate. There's no, ooh, what if, nope, blue, the end, right? That's the smell of gasoline. That is this taste, that kind of scenario. So colors and smells and sights, those guys. Skill memories are learned motor skills. So those would be those guys that we find in the premotor cortex, learning how to ride a bicycle, typing on a computer, what have you. Now your fact memories, again, are stored in different parts of the brain. So the color blue is stored in the occipital lobe. The sound of It's a Small World is stored in the auditory area, in the temporal lobe. So they're going to be in those different areas. With our skilled memories, again, they're going to be in the premotor cortex for those learned motor skills. And we also store some of those in the cerebellum because, of course, when you're riding a bicycle, you also have to know how to balance your body on a bicycle versus on two legs. So you'll have components in the cerebellum that communicate frequently with the cerebrum for those skill memories. Now, when we look at the types of memories, we have three classes, three categories. We have short-term memories. Short-term memories are also called primary memories. Those are the ones we're currently working with. It's kind of like if you're studying for, I don't know, a test or something this week, and you've got your notebook and your pencils and your note cards and your notes are all out on your desk. You're currently working on this information. That's your primary, okay? Now, when you have somebody go and take everything off of your desk without proper storage, it can really mess up your ability to find the things again, right? Or if you don't put stuff back where it goes, it's kind of hard to find the next time. Mm-hmm. That's what happens with memories. You're working with those primary memories. When you're done with that primary memory moment, like when you leave the room, you're going to store those memories so you can recall them later. And you're going to store them either as our secondary or tertiary memories in our long-term memory storage. This is also why a lot of times when you enter a room, sometimes you forget why you're there. Don't worry, it happens more as you get older. You're like, why am I in this room? Unless it's the bathroom, then I can guarantee I know why I'm in this room. But other than that, like, why am I here? That's because our brain perceives doorways as a stop point, as a new room, as a new set of information. So if that primary memory gets wiped as you walk through the door frame, you forget why you're in the room. Go figure, right? We forgot to store that little bugger. Yes.
So is that why, like, you forget to do something, you go back to where you were to remember?
Mm-hmm. Because it's like, oh, I left it on my desk. I can remember it now. You go back to the scenario you were in when you made that primary memory, and sometimes you can recall it a little bit easier. So you go back to the original source. Now, secondary memories tend to be hard to recall after a lot of time passes. Maybe we haven't used it a whole lot. Maybe we didn't see that it was important. It's kind of like last week or the previous week when I said, what is endothelium? And it was awkward for a few moments because we were pulling up that secondary memory of what endothelium was. If you take me for A&P2, end of March, I'll be going, endothelium. And we're like, oh, damn. Right? It'll be a secondary memory. It's going to be about a few weeks. You're like, oh, it's going to be hard to pull this one out. And then, of course, if I run into you at Walmart over summer and go, endothelium, it's okay. It's Walmart. You can pretend you didn't see me. And you're like, woman, leave me alone. But it's one of those so frequently. If you don't pull them out and dust them off and use them every now and then. Now, tertiary memories become a part of consciousness. Okay, so snow. If it's been a while since it snows and it starts snowing one day, you don't go, what is the cloud dandruff coming from the sky? You know what it is because it's a part of that tertiary memory. If you do some secondary memory frequently enough, it can turn into a tertiary memory. We see this a lot with skill memories. Like if you've ever been around, a nurse that's been a nurse for the past 20 years and they just do something really fast. You're like, wow, how did you know how to do that so quickly? They're like, I've been doing this for 20 years. That secondary memory, that job skill has become a tertiary memory, a part of the consciousness that they can just tap into really quickly. So when you've done something for long enough periods, you store it in a different location. It's easier to get to because it's now a part of your conscious activity. Yes.
What's the shortest amount of time you can use to turn something into a tertiary memory? Is there any evidence on that or no?
I have no idea. That would be psychology land. You would ask that question. We don't talk about psychology here. In this crazy silent CH. Now storage. When we transform primary into secondary or tertiary, that's known as memory consolidation. So combining memories together to form something we can recall at a later date. It's kind of like if you have loan consolidation when you're done with school, right? Yes, when you're done with college, you should do loan consolidation. It makes your monthly payment much smaller. Combines them together. Okay, so memory consolidation, you bring all those primaries and you combine them and turn them into a secondary, tertiary. So converting short-term into long-term. Now, it's crucial that you have the amygdala and hippocampus functioning to do this. So these areas can constantly make new neurons. They still have stem cells, so we can store new memories. And memory consolidation happens most efficiently while you're sleeping. This is why if you stay up too late at night, classic example, right? You stay up all night cramming for a test, you walk in and you forgot everything. It's like, why? Because when you were cramming for that test, you were working with primary memories. And if you don't stop to consolidate, you don't take a nap, once you pass through a threshold, usually the testing center, it wipes you clean. You're like, oh, it's all gone now because you didn't store it so you could recall it at a different time. So we notice this a lot with people who have insomnia. They tend to be forgetful. If you don't get a good night's sleep, you tend to be forgetful because you didn't consolidate properly. If there's anything that interrupts memory consolidation, you could lose that memory. If you've watched 50 First Dates with Drew Barrymore and Adam Sandler, if you pay attention when they describe her brain injury, they actually show a picture of her brain, and the area that is circled is the hippocampus and the amygdala. She's had damage to that. So every time she goes to sleep, she doesn't do memory consolidation. It wipes all of her primary memory. She loses that entire day and restarts. And so Adam Sandler is really not known for his biological accuracy in his movies, but in that case, they actually did a good job of matching up this is the area of the brain of hers that is damaged. This is what it's causing. She doesn't have a functioning amygdala hippocampus. She can't do memory consolidation. She forgets the entire day and starts over the next. Okay. Long-term memory storage, again, is happening in the cerebrum. So those fact memories, as mentioned, are going to be stored in those areas. So visual images are going to be in the occipital, and hearing is going to be in the temporal lobe, that kind of scenario. And of course, if it's skilled that needs balance and equilibrium, we'll also engage the cerebellum as part of that storage unit. Amnesia, right? Soap opera's favorite little problem to have this year. So we have two types of amnesia. Retrograde amnesia, again, retro meaning past. So this is where you forget your past. So you wake up and you don't know who you are or where you are. You don't remember last night because if you had a really awesome weekend and you were drinking a little bit much, you forgot to do some memory consolidation while you were drunk. It's gone. Okay, so those memories sometimes get lost. If you get blackout drunk, don't drink that much, right? Don't do drugs. Limit drugs. Mm-hmm. Anterograde amnesia, inability to store new long-term memories. So this is what Drew Barrymore would have. So some problem with the consolidation, so we're not able to store new ones. But you do keep all your old memories. Now, some drugs, again, can trigger this or cause anterograde amnesia. Usually they're sedatives. So Valium, Halcyon, these are the two big sedatives they usually give you before some kind of surgical procedure. So a lot of times you'll hear people's like, oh, I remember everything going into surgery until they gave me that shot, and then I don't remember anything. It's like, yeah, that was a good shot. Probably Halcyon or Valium. Okay, so yeah, it's got to be a sedative. It helps put you to sleep. But if for some reason you regain consciousness during surgery, you don't have the ability to form memory, so you can't remember the big hole in your body where you were having the surgery to your stomach or something, which I guess is a blessing. No one wants to remember some of those things. So if you know somebody who takes Valium or Halcyon to help them fall asleep at night, wait till the pill sets in. Ask for money. They may not remember that they lend it to you because they may have some anterograde amnesia. Oh, yeah. So here's just a lovely flow chart. So here's our short term, our primary, kind of like our table that we're working at. Repetition promotes retention. This is something that we probably learned, especially like high school, if you had to memorize a Shakespeare play like Romeo and Juliet. I know, you don't have that problem as much anymore. My kid hasn't read any Shakespeare. It's like, how did you get so lucky? STARS test, they're all learning about STARS test. Now they don't do anything until their senior year, and then by then they don't care. But anywho, back in the day, if you had to memorize Romeo and Juliet, wherefore art thou, you had to say it like 50,000 times to yourself before you repeated it to your teacher. Repetition promotes retention. It's kind of like when you write it on a sticky note. If you write enough sticky notes, you're going to run into one of those. Some cell's going to remember something. So that's why we tend to repeat ourselves whenever we're trying to memorize something, whether it's structures off of a model or what have you. Now, we can have permanent loss if the neurons get fatigued. If the neurons are too tired to consolidate, you're just going to lose that information. So again, we'll hear people say that a lot. Oh, I studied for hours for this test, and it was gone when I went to take this. Like, did your neurons get tired? Okay, don't let them get tired. They're like little 4-year-olds. They're very cranky when they get tired, and then they don't want to work right when they get tired, and then you fail. So it is better to study, go to bed at a normal time, 10 o'clock, 11 o'clock, get a good night's sleep, wake up early if you must, study some more. So you're bringing out that, you first consolidate that information, and then when you wake up and you study some more, you're bringing back out from consolidation to primary, then you store it again, then you go take your test. Because if you study all night through, by the time you go to take your test, your brain's tired and it's not going to be able to recall anything. And some stuff is just physically gone because it didn't get consolidated. Yes?
Can you consolidate? Let's say you study up until like 1 or 2 a.m., take a nap for an hour or two, wake up, do it again. Is that consolidating or not really?
There's a certain stage of sleep consolidation happens. I don't remember if it's REM sleep or deep sleep, but there's a certain stage. So if you hit that stage, you'll be able to consolidate. But if you don't hit that stage, it's not going to help you. It's kind of like sometimes when you take a nap, you wake up refreshed. Other times you wake up from your nap and you feel like you just died and you should have just stayed asleep. Depends on what stage you got into, where your body got to reset. So never remember that. My neurons are like, I don't care when you consolidate. There's a certain time that it's going to happen more efficiently. Shock will help you or prevent you from storing properly, so it's going to help you forget things. So we see this a whole lot if you have something traumatic happening, you had a car accident, it's like, I don't remember the car accident. It's like, because the neurons like, and they didn't store anything. Or interference from other stimuli. So this, if you're reading your notes and you're studying while watching TV and you get to the end of the notes and you're like, I know I just read something, but I don't remember any of the stuff I've done. Kind of like when you are driving and you end up at the Walmart parking lot, and you're like, how did I get here? Right? We got distracted by the songs on the radio. Same thing when you're studying. So if you get distracted by other stimuli, like the TV that's more interesting than your notes, or the music that's more interesting than your notes, or anything because they're more interesting than your notes, you're not going to be able to store that memory because you're being interfered with. So again, this is why they tell you to minimize distractions while you're studying. If you have to play music without words or in a different language like opera, because then it won't distract your general interpretive area, and you'll be able to read and process a little bit more efficiently. Once we consolidate it again, it'll go into secondary memories, where it might be able to be pulled up at a later date, it might not. So again, we might forget what endothelium is until I'm like, remember, I was telling you, it's over in histology, hint, 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 hint. We might bring it back up, or it might be permanently lost, right? I could ask you, what did you get for your 7th birthday? Unless it was epic, probably don't remember what you got. Okay? And each year it gets harder. So sometimes we're just going to lose those because we're not utilizing them. And of course, when we have them and we use them quite frequently, we just kick them over into tertiary memories, so we can easier recall them at a later date. So consciousness, this is when we are alert and aware of the external environment. It's always nice to get to this point in the notes and everybody is conscious. Doesn't always happen. I had one student, bless him, he helped everybody else in life, but he slept through every class. He was always there, but he just slept. So he was my example for the reticular activating system. It was like, dudes, isn't working, which was funny because it was back when we had tests in the class. So I could tell whenever everyone got to the question about the reticular activating system because they all looked at him. And then because he was the trigger for that memory, they're like, he didn't have a clue what was going on even during the test. Bless him. He's probably still sleeping somewhere. Yeah. He kind of sticks in your memory. His email was like Dr. something something at Yahoo. It's like, no, you're not. You're never going to be a doctor or anything with this unless it's Dr. Sleep. It's just not working for you. So hopefully we're conscious. Unconsciousness, varying states of unresponsiveness. Obviously, you can have the extreme where you have a coma and you can't be woken up even if somebody pokes you, prods you, or anything like that, all the way to the I'm just resting with my eyes closed. That one's always my favorite. Like, I wasn't asleep. I was just resting with my eyes closed. You're like, dude, you were snoring. You were totally asleep. Okay, so you have those varying states. And of course, sleep, we're not going to go into all the stages of sleep. That's, again, psychology really likes that. There's like chapters in psychology about sleep. So they get all up in there. So take psychology if you want to hear about sleep stuff. But what we care are the two big ones for body functioning. So deep sleep. When we're in deep sleep, we have very slow wave activity. This is non-REM, not the band. REM is rapid eye movement. So when you're in deep sleep, your eyes aren't moving at all. This is our break. Because again, your heart doesn't get to stop and take a breather like your skeletal muscles. That's called death. So during deep sleep, respiratory rates, heart rates, blood pressure drops by 30%. So it's the closest thing to a break that your heart's going to get. So you have to have so much deep sleep in order to function properly. Without enough deep sleep, not only can your brain go crazy, but it was also going to affect the health of your body. Now, REM sleep, rapid eye movement. So you know when you hit the stage because the eyes are just going back and forth like crazy. This is when the person is actively dreaming. So during this point, the reticular activating system, again, is shut down as a protective mechanism so you don't act out your dreams of being Muhammad Ali and beat up somebody that's, in the bed with you or run around or anything like that. So that's just REM sleep. And of course, arousal, when the reticular activating system is keeping you up and going, you have muscle tone, you're able to function and so forth. So here's our different brain waves. We have alpha waves. This is normal resting adults. So when, this weekend you're watching TV, your brain waves probably going to look like that. Beta waves, we typically see this with intense concentration. Bless you. So today's practical might have been a combination of alpha and beta waves because we might have been thinking hard about a question and then it might have been an easy question afterwards. Theta waves are normal in children. So alpha waves are resting waves in adults. Theta waves are resting waves in children. So children's brains, again, are very different than adult brain. Babies actually have way more neurons than adult brains do. What happens when you hit puberty, you actually start changing the configuration of your neurons. Some neurons just die out completely, and others reconnect with different ones. So during childhood, A and B might have been connected to each other, and during puberty, they release connection, and A now hooks up with D, and B now hooks up with C. So they change their pattern of communication. This is why teenage brains can be so problematic. This is why teenagers tend to be irrational, tend to have, emotional problems. They cry because the world's going to end because they didn't like my makeup, whatever. Okay. So we have a lot of changes going from the normal theta wave in children for activities to the normal alpha wave in adults. So during that rewiring is when we have a whole lot of changes to the neural tissue and a whole lot of reason why teenagers are crazy, which is always kind of ironic because you'll have people argue both sides. They're like, oh, well, they're 16. They should not be tried as an adult because their brain is changing and they didn't understand the consequences of shooting that person.
Oh, right.
Yeah, and these are the same people that are like, they should also be able to cut off their penis because they can make adult decisions. They can be a girl if they want to. It's like,
That's crazy.
so they can kill people and they don't understand the ramifications, but they're completely okay with changing genders or getting tattoos or piercings and voting. Which is it? Okay. If you're going to charge them as adults, sure, let them cut off their genitalia. But if you're going to be like, no, they're kids, then treat them. It's crazy. And of course, the best time to make decisions is not during puberty. It's when you're an adult, when everybody gets rewired, everything's set up, and you're going to be this way for the rest of your life. So you can make those healthy decisions because during rewiring, it's kind of like if you're rebuilding and rewiring your house that you don't make any drastic decisions. Craziness is going to happen. Now, we will see theta waves in adults when they're frustrated. It's not just because kids are frustrated. Okay? So hopefully today we had a lot of alpha waves, a little bit of beta, very few theta waves, hopefully. Delta waves, this is what we would see with deep sleep. So when we see those delta waves hit, we can look and see that the body, the heart rate's dropped and all that kind of scenario. Now, if you see delta waves and the person is conscious and talking, you should be careful. They're having a psychological problem right now. This is a pathological state. So when they talk about they had a break with reality, they had temporary insanity and, shot up the post office or whatever, whoever was going postal, Probably was having delta waves going on at that time. So if you see delta waves in a conscious individual, they've had a break with reality. So they might be murdering somebody at that point in time. Unfortunately, or fortunately, you can't see these whenever you're looking at people. Or you would be able to be like, dude, that person just hit delta waves. We should just back out of the room. And look at that, you survived all of the AP1.
Almost.
All right, so you survived listening to me yammer on forever in AP1.
Okay.
So tomorrow, since we are done with practicals and labs, we don't have lab. Look at that, you get extra long lunchtime. Or not, whatever. Y'all don't seem excited about extra long. I'm excited about extra long lunch. Anywho, so we will start lecture at 2 o'clock. Unless y'all want to vote and have lecture at 12:30 and then be done by 2.
I like 12:30.
So
I get to pick my son up.
they run wild. It'll be fine.
Okay.
All right. So who wants to lecture? And of course, lecture tomorrow is the review for test 5. Okay. So who would want to 12:30, and then we're done by 1:45, and we just study. Who says lecture normal time at 2 o'clock? You gotta have to talk to your peoples because you're a little loud enough. All right. Okay, fine. No long lunch. Sorry to get you excited, but we will review for test 5 from 12:30 to 1:45, and then you'll be free until Thursday.
Okay.
Is it in here or in the lab?
It'll be in the lab room because there's a lecture that happens during this time.
Here you said 12:30 here.
Lab room.
12:30.
So just go to the lab room, but instead of labbing, we'll be lecturing.
Lab room lecture.
Yeah.
Is our final in like person with you?
It's
Okay. And
So it'll be 12:30 and it'll be in the lab
it'll
room.
be in the lab room, and that's on Thursday.
Mhm.
And then our test 5. Yeah.
Opens tomorrow, closes Wednesday.
Okay.
Closes Wednesday.
So make sure you schedule your time.
Do you have any class on Wednesday?
No classes. So Wednesday is your dead day to take test 5, prepare for the final. If there was anybody who had to do a makeup practical, they would be doing it on a Wednesday, but nobody missed any practicals. So Wednesday is your day to be doing whatever you want to do. Yes, but don't tell your boss.
For the final, in your syllabus, it says we need to get a Scantron.
I provide that for you.
Okay.
So you just bring your pencil and your brain, and I bring the Scantron and